Hey, Bob here from Rosk. In this and the subsequent 3 short lessons, we're going to get into the specific vasoactive classes. We're going to start off with the vasoconstrictors, also known as vasopressors. These include phenylephrine, vasopressin, and angiotensin II. The main hemodynamic effects that these medications exert are an increase in systemic vascular resistance, and this usually results in an increase in blood pressure. We're going to start off with phenylephrine. Phenylephrine is a synthetic catecholamine and it's a pure vasoconstrictor. It activates alpha-1 receptors and has no significant effect on beta receptors. So activation of the alpha receptors causes vascular smooth muscles to contract. This narrows the lumen of the vessel and causes an increase in SVR. Common uses of phenylephrine include drug ingestions that cause pure vasodilatation, aortic stenotic patients in shock, and especially hyperobstructive cardiomyopathy and systolic anterior motion. They're ideal situations for the use of phenylephrine. Because when in shock, we treat these patients by fluid resuscitating and doing everything we can do to reduce contractility. So adding an inopressor would increase contractility. So for this reason, phenylephrine is ideal. I think many folks reserve this medication for select patients that experience tachyarrhythmias from other vasoactives. And then lastly, phenylephrine is a great temporary rescue stick pressor. Now, if you're unfamiliar with this terminology, think about your anesthesiologist dropping your patient off in the unit, and they have a front lapel pocket filled with pre-labeled syringes. One of these syringes are phenylephrine, and they use diluted IV boluses of this to rescue the blood pressure after induction for intubation. Now, there are some widely adopted concerns with phenylephrine. First, phenylephrine can indirectly drop cardiac output due to decreased forward flow. The best way I can explain this is to set a stage for an example. You have a septic shock patient with a left ventricular ejection fraction of 10%. You start phenylephrine as an initial primary vasoactive agent to support the mean arterial pressure. This causes an increase in SVR. It increases the stroke and cardiac work of the weak heart and increases myocardial oxygen consumption. It may also increase the left ventricular and diastolic pressure and causes further ventricular dysfunction. Phenylephrine can also cause a paradoxal bradycardia, and we think this is from a baroreceptor-mediated reflex from the abrupt increase in SVR and blood pressure. So some folks really seem to love this drug. However, when you step back and look, it's not even mentioned in the surviving sepsis guidelines anymore. So do I use phenylephrine in high heart rate situations when a patient needs a vasoactive? It really depends. If they have a preserved LVEF, and I mean in a real-time POCUS that I did at the bedside, not one from 4 days ago, a lot can change in 4 days, I do trial it, but very cautiously. So is there evidence to support this, or even to support the general use of phenylephrine? Well, not really, at least not recent literature. Now, I will say phenylephrine fans really cling to this paper that came out in 2022. Comparison of heart rate after phenylephrine versus norepinephrine, initiation in patients with septic shock and atrial fibrillation. Now, if you did yourself an injustice and just skimmed the abstract, you'd be led to believe that this was a very effective outcome. As you can see here, phenylephrine was associated with a modestly low heart rate compared with norepinephrine. Well, let's take a closer look at this. This paper was a retrospective observational review using a massive database. It was a single system and it included 9 other ICUs, and there was shy of 2,000 patients in the study. Now remember immediately, there's risk of bias since the patients weren't randomized. A provider could have selected either norepi or phenylephrine based on their own preferences or perceived risk for increased heart rate. It's impossible to know. Inclusion criteria required the patient to be in septic shock, AFib, and to have a SOFA score of at least 6. The 2 study groups were patients in atrial fibrillation rate controlled and atrial fibrillation RVR. RVR was defined as a heart rate greater than 110 in this study. Patients in atrial fibrillation RVR that were exposed to phenylephrine had a mean heart rate reduction of 4 to 6 beats per minute. Patients that had AFib rate controlled had a heart rate reduction of 2 beats per minute. While this is statistically significant, it means nothing to me clinically. In addition, there's plenty of extraneous factors that could have brought a heart rate down from 2 to 4 beats per minute. In fact, a small number of patients were exposed to rate rhythm control medications, including amio, beta blocker, calcium channel blocker, and digoxin. Beta blocker use was actually used in about 11% of the population at the 6-hour mark. In addition, the mean pressor dose was not overly impressive. It was 0.12 mics per kilo per minute of norepinephrine equivalents. And then oddly, 33% of the population was in their cardiac ICU. This really didn't make sense to me since these were septic shock patients. And one of the items most important to me is that 55% of the population had heart failure. However, the paper didn't define what type of heart failure or the chronicity of heart failure. So with the exception of paradoxal bradycardia, my biggest concern is an indirect drop in cardiac output in patients with low LVEF, or maybe said more correctly, a reduced stroke volume secondary to poor ejection. With that said, let's move on to vasopressin. Now, vasopressin is also antidiuretic hormone. It's a nonapeptide, and this may be misleading at first. You may see non and think it's a non-peptide, but nana actually means 9. So vasopressin is a 9-peptide hormone. It's composed of 9 amino acid residuals. It's normally formed in the hypothalamus, and it's released in the posterior pituitary. And while the hormone has multiple functions, we're going to focus on two. V1 causes vessel constriction, and V2, the antidiuretic hormone effect, increases water reabsorption in the kidneys at the collecting duct level. So in actuality, this medication has the potential to increase SVR and conserve blood volume. A quick note on dosage. For septic shock, it's 0.03 units a minute. This is non-titratable. Essentially, we're using this agent to supplement or replace a presumed vasopressin deficiency that we see in septic shock. Think of it as a hormone replacement or a synergistic supplement to your catecholamine regimen. For other disease processes like pulmonary hypertension, RV shock, and vasoplegic syndrome, we can use it as a titratable vasoconstrictor. I'm sure we've seen a wide range of doses out there, but taking into consideration available literature and weighing risk versus benefit, a reasonable dose range is between 0.01 and 0.06. I've definitely seen higher, but with those higher dosages, we worry about limb, digit, and gut ischemia. Now, vasopressin has some interesting properties. It appears to not affect coronary or cerebral vasoconstriction as much as catecholamines. The medication also seems to function synergistically with norepinephrine, and its vasoconstrictive effects are preserved in hypoxic and acidotic environments, unlike catecholamines. This is huge. Catecholamines require a very narrow spectrum of pH to function, where vasopressin does not. And then lastly, its vasoconstrictive effects are selective to systemic vessels only. This translates to not increasing pulmonary vascular resistance as our catecholamines do. In fact, in some animal models, it's even been shown to reduce PVR and PVR-SVR ratios. This makes it an ideal agent for pulmonary hypertension and RV shock. And now let's move on to angiotensin II. Angiotensin II is an octapeptide. It's a very important part of the renin-angiotensin-aldosterone system, and among other things, the system plays major roles in volume, sodium, and blood pressure control. Very briefly, angiotensin is a peptide prohormone. It's produced primarily by the liver. When the blood pressure drops, the kidneys release renin. Renin causes an enzyme-like reaction that forms angiotensin I. Angiotensin I is then converted to angiotensin II via angiotensin-converting enzyme, and this occurs primarily in the lungs. Angiotensin II causes an increase in sympathetic outflow, and at the bare minimum, it's thought that this effect may reduce baroreceptor-induced bradycardia that we might see with other vasoconstrictors. Angiotensin II triggers the kidneys to release aldosterone, and aldosterone causes sodium and water retention while increasing potassium excretion. Angiotensin II also causes the pituitary to release vasopressin, and we already know one of the vasopressin's functions is to increase water reabsorption. And then lastly, angiotensin II causes a smooth vascular muscle activation, causing intense vasoconstriction. Now, I'm going to break my promise about not going into in-depth literature discussions. However, angiotensin II, at least in my eyes, is a drug still looking for a home. We won't cover it much in future lectures, so I want to spend a bit of time on it now. While it's relatively new in regards to FDA approval, it was discovered over 50 years ago, and a bovine formulation has been available for at least 35 years. Interest in the product fired up again around 2009, then a human synthetic form was introduced and approved by the FDA in 2017. So for mainstream use, it's pretty new and it's left us scrambling to understand how to use it. Its FDA indication is for distributive shock, and most would say catecholamine-resistant distributive shock. This is the medication's initial pilot trial out of George Washington University. It included 20 patients. Inclusion criteria was that the patient had to be in distributive shock on norepinephrine and had to have a SOFA score of 4 or greater. In conjunction with their norepinephrine, 10 patients received placebo and 10 patients received angiotensin II, starting at 20 nanograms per kilo per minute. The primary endpoint was the effect that angiotensin II infusion had on the standing dose of norepinephrine. So the addition of angiotensin II resulted in a significant reduction in norepinephrine doses at 1 hour. The control group, the placebo group, had a norepinephrine dosage of 27.6 mics per minute, where the intervention group, the angiotensin II group, had a norepinephrine dose of 7.4 mics per minute. So this is the pilot study that got them on the map for being a potential rescue agent in distributive shock, and a few short years later, the Athos 3 study was published. This was a multinational, randomized controlled trial. It was industry funded by La Jolla. In fact, one of the study's investigators was a CMO of the farm company at the time, and this paper is what gained FDA approval. Generally, this was a sick population of patients. There was a mean Apache score of 28. There was reasonable exclusion criteria after randomization, and the two inclusion criteria worth mentioning are the patient had to be on at least 0.2 mics per kilo per minute of norepinephrine or equivalent, and the patient needed to be in vasodilatory shock. Now, there were detailed criteria to define vasodilatory shock. This included a cardiac index greater than 2.3 liters, a SCVO2 greater than 70, a CVP greater than 8, and a MAP between 55 to 70. 70. So the latter criteria was a little bit awkward to me, but I feel it's worth pointing out. In the intervention group, without increasing any background vasoactives, angiotensin II was started at 20 nanograms per kilo per minute and titrated. I feel it's important to point out that about 70% of the patients were also on concurrent vasopressin. The study had appropriately powered primary outcome endpoints, and this was a response in MAP at 3 hours that equated to either an increase in MAP from baseline of at least 10 millimeters of mercury or an increase in MAP to at least 75 millimeters of mercury. The secondary endpoints included changes in SOFA score, safety adverse events, and all-cause mortality at 7 and 28 days. Now, like always, I'll point out that a secondary endpoint is hypothesis generating. So let's take a look at the results here. The primary endpoint of increasing the MAP at least 10 millimeters of mercury or reaching a MAP of at least 75 was reached 69.9% in the angiotensin II group and only 23.4% in the control group. As far as secondary outcomes, the cardiac SOFA score was reduced in the angiotensin II group, but the overall SOFA score wasn't affected. Two things to say about this. Of course the cardiac SOFA score improved. It did it because the MAP improved with therapy. But this is a nice example of a secondary outcome supporting the primary outcome. However, why didn't the overall SOFA score reduce as well? This wasn't disclosed, at least clearly in the paper. I'm not a mathematician, but you would think the overall SOFA score would increase in combination with the improved cardiac SOFA score. It actually makes me worry that another component of the SOFA score worsened. Adverse events were not significant. However, I'd like to point out that the package insert states a 12.9% rate of DVT with the use of angiotensin II. It's difficult to ascertain the validity of this, but it definitely concerns me. From this paper, the paper that gained FDA approval, it leaves you still curious on when to use it or even to use it. Making it even more difficult, the pharmaceutical company that produces angiotensin II has excellent sales and farm reps. They could sell ice to an Eskimo if needed. So it really makes the whole process of understanding angiotensin II very difficult. One item of contention that advocates of angiotensin II surmise is that we currently start angiotensin II too late. I do think this is somewhat of a reasonable hypothesis. And this triggered a reanalysis of the Athos 3 paper. If we look back at the Athos 3 paper, while one of the inclusion criteria is a norepi dose greater than 0.2 mics per kilo per minute, that's not what the study population actually reflected. The medium norepi dose equivalent upon enrollment was 0.34 mics per kilo per minute, which is right around the dose that I would consider angiotensin II, given the patient was also on vasopressin. Looking even further, nearly 30% of the Athos 3 population got enrolled on norepi equivalent doses greater than 0.5 mics per kilo per minute. So this paper is an exploratory post hoc analysis of the Athos 3 trial completed 5 years after the main trial. Patients were grouped into low-dose norepinephrine that's less than 0.25 mics per kilo per minute and high-dose norepinephrine, which is greater than 0.25 mics per kilo per minute. The primary outcome was the difference in 28-day survival, and it found that the angiotensin II patients that were on lower norepinephrine doses were about half likely to die. It had a hazard ratio of 0.509. But again, this is hypothesis generating. This was an unplanned post hoc analysis done nearly 5 years after the initial trial. In addition, the Athos 3 paper originally wasn't even powered to detect mortality. And then lastly, the low-dose norepinephrine subgroup only had 56 patients in it. So again, we have to take this with a grain of salt, consider it hypothesis generating, and even the paper's conclusion states that a prospective trial is needed to be formed in order to draw a conclusion. Now, most recently in 2003, folks asked the question, what about angiotensin II as the primary vasoactive medication? So this was just a pilot trial. It was a 40-patient pilot study exploring angiotensin II as the primary vasoactive agent in shock. It didn't appear to be harmful. It had lower ICU mortality, but this didn't result in 28 and 90-day mortality reduction. Creatinine levels and incidence of AKI, CRRT, and major adverse kidney events didn't differ either. So where does this leave us? So one layer of contention to add to this. Angiotensin II costs about $1,500 a bag, and that bag lasts a 70-kilo patient on moderate conservative doses of angiotensin II approximately 24 hours. A reminder, the FDA indication is for distributive shock, and most still would say this is refractory vasodilatory shock. So personally, I still feel there's a paucity of data. Angiotensin II works to improve the MAP, but I still worry about adverse effects and harm. I would be cautious with its use in patients with or at risk for bronchospasm and LV dysfunction. I would also be hypervigilant with DVT prophylaxis and monitoring. It's definitely in my toolbox for vasopressor refractory shock. However, I only consider it at this time on a case-by-case basis, weighing the risk versus benefit ratio carefully. I think doing otherwise outside an academic trial-like situation might be jumping the gun a bit. Well, this concludes our quick lesson on vasoconstrictors. Next up, vasodilators.